Well, I couldn't imagine a more fitting introduction given the nature of the talk this morning, and I'm glad it was prefaced by a little bit of discussion with regards to policy changes in patient monitoring at Mount Sinai. So as Dr. Ferry has mentioned, one of the things I've been very interested in is healthcare policy and how we can be proactive as physicians in changing healthcare policy as it's implemented earlier on. So today I want to talk about policy and its pitfalls, hemodialysis access as a model for improvement. And I promise you I'm not going to delve into the world of hemodialysis access and talk about data and arteriovenous fistulas for hours on end. I want to make this universal, and hopefully everybody can find a way to apply it to their own specific practice. So when Elizabeth Fee, who's a PhD at Johns Hopkins, wrote a written commentary of the Affordable Care Act, one of her leading quotes was, "Public health is oriented towards the analysis of the determinants of health and disease on a population basis, while medicine is oriented towards individual patients." And she was trying to describe the dichotomy that exists between public health policy in this country, as well as against the providers of that public health policy, which are the individual physicians. So if we do just a brief overview, and you'll indulge me for a second, if we're defining health policy as planning and development and implementation of interventions designed to maintain and improve the health of a group of individuals, and we transition over to what our medical care is, which is healthcare services provided to individual patients, generally in response to or in anticipation of acute or chronic illness, you begin to see where the data for these two different patient populations may be antithetical and actually compete against one another. So if we go back to Brian Coakley's talk earlier in the year where he focused on dogma and evidence-based medicine, one of the big things that we could have taken away from that ground rounds presentation is that in the healthcare community, when we focus on our delivery of medical care, we're really looking at evidence-based medicine. It's something we all strive to do. We look at clinical studies, we look at actual research, we focus on meta-analysis, randomized controlled clinical trials, uncontrolled trials, case series, and all these give us data which guide our daily decision-making. And we look at patient-directed outcomes, and we also look at patient-oriented outcomes. And based on this data, we're able to have great conversations like we had this morning at M&M to tweak how we deliver care. And we do this because we have recommendations that are put together by our societies. And these are recommendations. They aren't algorithms that you have to adhere to strictly. And so when we talk about level 1 evidence, level 2 evidence, 2A, 2B, it's because physicians who are researchers on the clinical level took the time to gather data and do it in an organized fashion so they could come up with algorithms that would allow us to approach the care of our patients. But the issue then develops into what Ronald Coase said, who was the Nobel laureate in 1991, where if you torture your data long enough, it'll confess to anything. And that resonates particularly as somebody about to become a vascular surgery attendant. If you're going to do something to a patient over and over and over again, and you're going to sub-select and create exclusion criteria when you're designing the research trials, ultimately you can come up with data that'll support any decision you're going to make, which is the importance of, as Dr. Ferry has mentioned, peer-reviewed journals. And we allow for some controls to be engaged as we practice our medicine and report our data. So one of my favorite comics pegs me as a dork, which I am. It's XKCD. And essentially, this becomes the problem with statistical significance. And I swear we'll move on shortly. But jelly beans cause acne. Great, let's analyze all the colors and see which jelly beans actually cause acne, because overall, if we look at them, they don't really cause any problems. Well, if you look at 20 colors of jelly beans, if you're looking for a p-value of less than 0.05, naturally one of them, by the incidence of statistical significance, is going to cause acne, which is going to cause an outcry on the public level. And we begin to see how we do research that's dedicated towards the patient and how the policy wonks take that and generalize it to the population. And we start to see where's that tension arises. So if you look at what you do as a surgeon, you make decisions on a daily basis. And a lot of times you're alone in the operating room. And when you're making your decision, it's you, your knowledge base, your experience with that patient, and your understanding of what that patient's family characteristics are, their values and their preferences. And you have to make that decision, and nobody else. And you can rely on the data that's been previously reported, but it's an individualized approach to an individual situation. When I was in medical school, though, I got to have a very large view of this, and my first healthcare policy exposure came from William Kissin. He essentially designed Medicare and was one of the first presidents of CMS. And what he wrote in Medicine's Dilemma is he coined this idea of the iron triangle. And the iron triangle has now been adapted to many different things over the last 40 years. But essentially what it says is there are 3 legs when it comes to the delivery of healthcare: cost, quality, and access. If you alter any one of those, you're going to affect something else in the triangle. And when he was putting this forward, if you're going to lower costs, you have to limit access, or you have to limit your options. If you're going to improve quality, you have to make some cost adjustments because you're going to look for mechanisms to which control that quality. So everything is tied together in his mind. And you fast forward now to what we do when it comes to policy. Essentially, modern policy is dictated by this eightfold path that was put forward by Eugene Bardock at UC Berkeley a few years ago. And what he says is when you're generating policy, and it's healthcare policy, you have to follow these 8 steps. You have to define your problem, you have to assemble some evidence, construct your alternatives, select the criteria, project your possible outcomes, which in the case of healthcare policy is savings and quality, confront your trade-offs, decide and share your results. And the thing I want to hone in on is when you look at what this guy has suggested as being the foundation of healthcare policy creation in the United States, is it's not fully based on scientific evidence. They go back and they select the scientific evidence that they think is most appropriate and to support their needs. And there's a lot of overlap in this Venn diagram between scientific evidence, political will, social infrastructure, and from that we create our healthcare policy. And the last thing is the most important, share your result. Eugene Bardock says that if you can't convince a New York City taxi driver who tend to be less educated and hard asses, then you shouldn't be proposing your policy in the first place. So keeping this in mind, if we look at healthcare policy and we look at medical care, and we start to see where the tension is, I want to sort of elucidate a little bit more before we talk about hemodialysis access as a means of proposing solutions and how we can be more proactive in influencing policy in this country. So if we go back to medical care, that's all of us sitting in this room, when we focus on decreasing costs, and it's somewhat of a sensitive area, we're not necessarily saying that you have to decrease your earning potential. You're allowed to put your kids through college, buy your Tesla, live in Westchester, come into the city, and have a really great life. And you can decrease costs for the hospital system while maintaining your standard of living. So the two things aren't necessarily antithetical. And a great example of that is if you look at our own vascular lab. So CMS says that you can't do an arterial duplex or a venous duplex on the same day. And if you do, they'll pay you less for the second study. So what do? Schedule one on Tuesday and one on Wednesday. The hospital makes the most money, the physician makes the most money, and the problem has been averted. Are you breaking the law? No. Are you operating in a gray area? Potentially. But you're working within the system to provide quality care for your patient, and you're also aware of the limitations that the system has put on you in order that you can put food on your table and have a good standard of living. If you're a physician, you also want to increase quality. And this is really important. I don't think anybody in this room would go home and say, I really want to do worse by my patients today. Although we could argue that sometimes. But if we're focused on increasing quality, we have that large neutral zone that I'm talking about. We have randomized controlled clinical trials, sure, but we also have case series and smaller patient populations that we have to work with. And as we work with these smaller case series, they don't really provide you with a definitive answer. And so you're focused on what you think is best for your patient. So there's really interesting research that's come out of Massachusetts from this place called Harvard. Dr. Lozzi may know it. And one of the great things is there's this woman there named Nancy Keating, and Nancy Keating is a huge advocate in terms of looking at physician behavior for predicting outcomes for patients. And if you look at the use of bevacizumab for breast cancer treatment, this is a great example that she's put forth to say physicians do what's best for their patient, but they also can do what's best for themselves, and the two aren't antithetical. So if you look at the administration of this drug after the FDA approved it for the treatment of breast cancer, and because it was physician administered, it means that physicians have to put money in their pockets. So utilization skyrocketed across the board. But gradually, the FDA put more and more rules in place limiting its administration. And what she found is as those rules went into place, before there were financial incentives to stop using the drug, physicians stopped using the drug. So what this means to me, and what this means to a lot of people, is that overall, everybody sitting in this room tends to be responsible. We follow these ideas of beneficence. We want to do good by our patients, regardless of the financial implications, and sometimes if it means making money, we can do that as well. But now if you shift to the healthcare policy side of things, this is where some tension arises. Health policy wants to decrease the cost to the system. This is their ultimate goal. And to do that, they want to limit options, because the fewer things you have on the shelf, the fewer things you have to stock, the fewer contracts you can negotiate. And for those of us who have interacted with the operating room, we know that this is a constant debate that happens on a daily basis. And this is how we contain costs. And if you want to increase quality, you have to do quality performance analysis and do outcomes analysis as well and study these things. And a great example of how the government does this from a policy side is looking at the use of essentially erythropoietin drugs in the early 2000s. So if you focus on Part B billings for drug expenditures prior to 2007, 43% of all drug expenditures by Part B Medicare were held by 6 drugs alone. And of those 6 drugs, 3 were used for hemodialysis patients. And so you could say that almost 17% of all expenditures in terms of Part B medical reimbursement were directly related to unbundled fees that paid for hemodialysis, erythropoietin medications. So what did the system do? Well, they put cost containment measures into place. So in 2008, they published bundled payment guidelines, which they no longer reimbursed because they said this practice wasn't evidence-based. And without evidence to support the use of epogen in the hemodialysis clinics, they didn't need to pay for it. And there was a dramatic change. So if you look at this chart, you see since that implementation went into effect in late 2009, the threshold for which we accept patients with hemoglobin levels of essentially higher than 9 has increased in our hemodialysis patient population. And this directly correlates with a decreased use of epoetin overall. And essentially what you'll see is the same trend. The 2 parallel one another. So there was a cost containment measure put in place by our policy wonks designed to contain cost because the cost that we were incurring wasn't related to outcomes whatsoever. So it comes back to this Venn diagram. And as Donald Berwick said, and I know some people in the audience may disagree with him, he was the head of CMS essentially for the first half of the Obama's first term, policy should not pit providers against their patients, nor exclude them from fulfilling their duties. But I know that there are a lot of people, especially in the vascular surgery community, who sometimes feel like healthcare policy is levied on us, and it does do that. It does exclude us from fulfilling our duties, and it is limiting. And so there are all these agencies out there, and I'm not going to go through all of them, but essentially the government has set up multiple systems that provide them with data with regards to cost analysis, provide them with data with regards to outcomes and to access, and it pits their data against ours. And so what I'm advocating, and I want to talk about as hemodialysis as a model for, is we change the tone of the conversation. So if you look at what our role is, we talk about clinician educators, we talk about physician researchers, we talk about physicians as diagnosticians. But one of the things that we don't talk about very often is physicians as policymakers. And we can gear our clinical research in such a way to influence healthcare policy in this country without sacrificing our own quality. And so if we can change the basis of our scientific evidence and the way we produce it, and change its language and its tone so that it focuses in on political will, on public policy, and on social infrastructure, essentially we've made our Venn diagram as big as possible. And I'm not trying to support the idea that Stephen Abramowitz has difficulty with authority. I'm sure many people in the audience would argue that already. But what I am saying is that there is a role for us to be proactive in questioning the system as it exists. And I want to talk a little bit about how, and why hemodialysis is the perfect example in which we can do this. So hemodialysis access is really interesting, and essentially the Social Security Act of 1972 told us, hey, the government's going to pay for everything, which was pretty fantastic. They said Medicare Part A and Part B will give nearly universal coverage to all patients who have end-stage renal disease and require hemodialysis. And those are the patients who are on hemodialysis as well as peritoneal dialysis. And they've been charting those results for the last 40, 50 years because it's been such a substantial part of our healthcare spending in this country. 7 cents of every dollar spent on healthcare in the United States goes to a hemodialysis patient. That's nearly 10% of our healthcare spending in this country. So if you look at that, they've been trying to come up with ways to cost contain, especially as the healthcare costs in this country rise. So the Medicare Improvements for Patients and Providers Act of 2008 put forth the first prospective payment system with regards to Medicare reimbursement in this country. And essentially what they said is, look, we're paying for all these hemodialysis patients, we have to cover them. What if we start bundling payments? What if we create a government-sponsored primary payment system in which we track all the data, we know all the results, and we can limit the amount of money that we're hemorrhaging on these patients? And that's exactly what they did. So if you look at our access patients and you want to study how we can influence healthcare policy, they are perfect. Because essentially we've eliminated this one axis of our triangle, which is access. We know that they're all covered. On the first day of their 4th month of being on hemodialysis, everybody converts over to Medicare. So our government has provided access for our hemodialysis patients. And in doing so, we can focus on cost and quality and not have to worry about healthcare coverage or health insurance. So if you look at Michael Leavitt's testimony to Congress in 2009, he was the head of CMS, HHS at the time. He gave a great presentation. He said, okay, so we're putting together this prospective payment system. We're going to expand our Part B ESRD bundle, and it's going to pay for all of these things cumulatively. You can't individually bill. No longer we're going to pay for individual doses of epogen. We're not going to pay for individual labs to be sent out to the patient. It's all one payment. And it was great. He came up with this wonderful algorithm. There are 3 agencies in the government that are responsible for tweaking this algorithm on a yearly basis. I won't go into all of them now. But essentially they say, we're going to give you a base rate. We're going to put some modifiers in there based on where you live, how sick your patient is. But this is it. If you spend more, it's your loss. If you spend less, you save. But of course, anybody who's worked in a VA system knows if you spend less, the next year they're going to say, well, you didn't need that money, so we're going to hold it back too. And that's the danger of having somebody else dictate our policy decisions without other data showing that there is gray area in which we can operate. So the other danger in this is the other thing he proposed. And in 2009, essentially what Leavitt said to Congress is, now we need to move to quality assessment. And this is something that we've all talked about with the Affordable Care Act, especially in the construction of ACOs, which hasn't impacted the surgery community much yet, but it will, is that if you have patients who have a surgery and they have a negative outcome, you're going to be dinged. And soon it will be, is if you have a certain number of negative outcomes, your hospital system will be dinged in terms of the reimbursement. And it's coming, because if you read his testimony, the last thing he proposes is this wonderful chart of saying, so right now I'm saying we should start with these 4 boxes, but by 2016, let's add these other boxes on the bottom. And the big box that we can talk about is vascular access services. So why is vascular access this great way for us to talk about healthcare policy? Because we know it's coming. It's inevitable. The Affordable Care Act talks about it. In the original testimony to Congress, they talked about it. So down the road, we know that vascular surgeons, interventional nephrologists, and interventional radiologists are going to have to confront healthcare policy directly dictating our reimbursement and our practice guidelines for dealing with vascular access. So how can we influence imminent policy changes through focused clinical research while benefiting our institution and our patients? It's completely possible, and I want to talk today about how we can, as a community, build out our pink bubble. We can make our scientific evidence sort of the foundation and the dominant thing in this Venn diagram. So first, if we go back to Bardak's principles, we have to define our problem. And in our problem, we have access. So hemodialysis access options for end-stage renal disease patients essentially remain the same for the last 50 years. And you know, it's striking how consistent it's been. You have a fistula, you have a graft, or you have a tunneled central venous catheter. And I promise you I'm not going to go into the construction or all the data about these 3 things. And then we have quality. You have hemodialysis access outcomes have seen little improvement despite new maintenance technologies. So for all the ballooning, all the stenting, all the angiojetting, all the different things that we want to do to the central venous system to make sure that we have primary functional patency or secondary functional patency rates, essentially a fistula and a graft last between 24 and 28 months, and whether it's 1972 or 2014, that data has remained relatively constant. So we haven't made many strides in terms of our own quality. And in terms of cost, maintaining that functional patency for life-sustaining access, and that's the key thing here. Hemodialysis access is life-sustaining, is a costly thing in terms of economics, time, and resources. So you have this permacath, which is a one-quick shot. It stays in the patient. We'll debate that in a second. And it's essentially the most cost-effective thing versus fistulas and grafts. And now we're talking about money and data. And so where do all these things fit together? So you have the major agencies on the left. The United States Renal Data System, the National Kidney Foundation, the Department of Health and Human Services. You have Crown Web, which takes the individual data reported from each dialysis session at every hemodialysis facility in this country and centralizes it so it can be analyzed by the Dialysis Outcomes Practice Pattern Study Program. So these are massive data collection systems, essentially because the government said, we're paying for it, we're bankrolling it, we should understand it. And then you have the scientific research on the side. So you have the kidney journals, the vascular surgery journals, the general surgery journals, the Society for Vascular Surgery, interventional nephrologists. They're all of us generating data that's very patient-specific, very focused, very granular, but we're not seeing a translation of our research into policy changes. We're just seeing changes in policy without any real research grounding. And this is why. I will not go through all of these, I promise. But if you do a simple Google search and ask for algorithms for hemodialysis access, this is what you come up with. And these are all based on PubMed articles. So every single physician for the last 40 years has thought that there's a silver bullet. They can come up with a better algorithm, a better way of approaching the hemodialysis patient, and a better way of providing quality, durable access for all of these patients. But they haven't been able to. And these algorithms haven't been successful. And the reason goes back to this idea that our research, in some ways, is fundamentally flawed. We have exclusion criteria. I'm guilty of it too in my own work, and we're guilty of it across the board. If you look at the stenting trials for coronary artery stenting, end-stage renal disease patients were excluded from those trials. If you look at our ideas for fistula patency in this country, a lot of patients who had prior hemodialysis access were excluded from those trials. So by building in our own exclusion criteria, we essentially build in our own failure of statistical significance. And when it comes to translating our work into policy, every algorithm we want to generate or come up with is flawed. And anybody who's making policy based on our research is only left to cherry pick. And they can only look at that small part of the pink circle in terms of creating their policy in the first place. And this is a perfect example of it. So if you look at the Fistula First initiative, this is an organization that came out of CMS. And they created these end-stage renal disease networks. And essentially what they do is they go around and they say, fistulas are the gold standard. They have superior patency. They have lower complication rates. They've improved adequacy, and they're a lower cost to the healthcare system. But if you go through the Fistula First website, the interesting thing about it is there is 0 level 1 data. There's actually 0 level 2A data to support their assertions. It's a bunch of clinical trials, consensus guidelines taken from different societies. Now the problem with this isn't that they're saying that fistulas are good. The problem with this is CMS has adopted this. So Fistula First is now linked in with CMS. And if you don't have a certain number of fistulas in your hemodialysis clinic, you're dinged. You don't get paid as much money. And so we're seeing policy come out of recommendations that are consensus guidelines that lack level 1 evidence. And I would argue that the fault is within all of us. Because when it came time to predict what policies were going to be put into place, we didn't change our tone, and we didn't refocus our research to be proactive in advocating for our patients, to come up with policies that both benefit them, contain costs, and allow us to do what we want to do for our patients. So in terms of looking at our iron triangle and going back and approaching our patient population and applying this for hemodialysis access, one of the things that we tried to work on over the last 5 years with Dr. Paderescu and Dr. Schanzer was this iron triangle, and how can we generate valuable clinical research that has good impact in terms of its scientific merit, but also has that greater applicability in terms of generating functional policy. And we were able to do that, primarily because Fistula First doesn't deal with these issues. And that fact is, it costs $35 billion a year to provide hemodialysis for our patients, 380,000 of them. And that's 7%, as I said before, of our spending. And that's $90,000 per year on each patient. And so when you look at those numbers, you're like, oh, well, the government has it all. Where am I going to make an impact? Well, they don't have it all, because you have to find the flaws in their data collection system. And so if you're going forward, I'm going to use hemodialysis access as a model, but you want to study, let's say, something in general surgery or pediatric surgery, find where the gap is, and find out where you think that policy gap is that needs to be answered. And for us, this was, if you looked at the cost of access creation and the maintenance of that access, the issue was that that data was lost. USRDS, DOPPS, all of these agencies only kick in on the 4th month and the first day in which a patient is on hemodialysis. Because of that, they miss 1/3 of the first year in terms of cost, and they also miss the surgical procedures that get linked up to future procedures, so they're unable to predict total outcomes for these patients in maintaining their functional patency. So this was our golden window. And this was our opportunity as we approach this data to influence future public policy, because we know it's coming in just a few years. They're going to generate algorithms and reimbursement guidelines based on the data that's available. So we do have this narrow window in which we can influence policy. And again, focusing on the data that they do have, you see these gaps, although they don't acknowledge it. So this comes from the USRDS database, and essentially the USRDS system is responsible for gathering all of the aggregate data when it comes to hemodialysis access in our patient population across the country. And you see, in the first session, everybody has a catheter. But the Fistula First Breakthrough Initiative then says, just a few months later, 66% of patients have a fistula. Well, the issue is they have no data. They have Crown Web data from that first interaction, but they have no primary payer data up until that 4th month. So we can fill in that gap by asking some very specific questions. How can we guarantee quality of access functional patency? How can we guarantee that our patients have quality outcomes in terms of related complications, including occlusion, infection, fatal access hemorrhage? And how can we look at access-related interventions, including radiation exposure or access-related hospitalizations in terms of bacteremia and other complications associated with their dialysis access? Well, it's really easy. We have the granular data. And in focusing on our granular data, it comes back to what our approach was. When you focus on dialysis patients, the system is set up to look at billable events. and it's looking at their individual point interactions with Medicare as a primary payer system. And that's what the policy is entirely based on, because that's the data they wanted to collect. But our end-stage renal disease patients, and I would argue a lot of the patients that we treat, either for irritable bowel disease, Crohn's, some of these things that are chronic conditions, these are chronic conditions that are treated by a system that's been designed to provide acute care and designed to respond to acute care in terms of policy. So we don't have very good long-term policy algorithms for dealing with our dialysis patients, and we can study that. We can look at public health, their interaction, population health, health policy, so on and so forth. And so one of the other things that aids us in doing this is that the amount of time someone lives while they're in hemodialysis has increased over the last few years. No longer when you put someone in hemodialysis do they die right away or within 2 or 3 years. You see the percentage of patients living in rural and non-rural areas, according to a dialysis outcomes study, essentially shows that more patients, almost half of them, are now approaching the 5-year mark in terms of their life expectancy after being placed on hemodialysis. So you have a cost sink, you have a patient population that's not going away, and you can provide the data that gives a long-term strategy for treating them. So what we decided to do was use our economic data as a surrogate for clinical events. And this is open for debate, and I'd be interested for any questions or discussion as we move on. But we can suggest gaps in recurrence of current policy situations by simply looking at dollars and cents. Instead of focusing on how many times a patient needs an embolectomy after their fistula is created or their graft is placed, focus on how much that procedure costs. Right? It's a marker for what we're doing clinically, but it translates into dollars and cents for somebody who's interpreting what you've done clinically in terms of making policy for reimbursement guidelines. You're changing the nature of your reportable event, and you're changing the language a little bit, but it's just a translation. And you can still keep your scientific validity by reporting both in your same paper. And I apologize, this isn't planned, but this comes from the Mount Sinai Data Warehouse, and this is one of the powerful tools we have here at Mount Sinai. If you haven't played around with it, I encourage you to access it, but it's a phenomenal resource. And you can literally go into the Mount Sinai Data Warehouse and find any ICD-9 code, or soon to be ICD-10, any ICD-9 code, find out where they live, what they've done, what their demographics are, and literally data mine anything you want about your patients and pull their records. The great thing about that, it is a granularity that does not exist on the national level. So if you start talking about policy and that gray area and the things people are missing in terms of pre-existing research, there is some validity to saying, look, we're a tertiary care facility in a major metropolitan area. We see the worst of the worst cases when it comes to dialysis access. We see the patients, when you say you have 60% functional patency at a year, we see the 40% that didn't achieve that goal. That's the facility we're at, and that gives us a real strength in terms of reporting what our outcomes are in terms of the economics of providing dialysis access. And that's what we did. So before that, we were able to go to the Mount Sinai Data Warehouse, and we were able to say, look, our data is just as good as anywhere else in the country. Our patency rates for fistulas, radiocephalic, brachiocephalic, brachiobacillic fistulas, our arteriovenous grafts, they're all the same. Our incidence of infections from perm paths or other tunnel lines are exactly the same nationally. But now that we've proven that we're just as good as everybody else, let's show where our exceptions are and our gaps are, and hopefully we can now make this an issue for policy everywhere else. So the first thing we did is we looked at age. Because the Fistula First Breakthrough Initiative doesn't say if you're old, don't get a fistula. It doesn't say if you are African American, diabetic, and female, don't get a fistula. It says everybody, no matter what, if they have a vein, should get a fistula. And that just can't be the universal policy. Medicine doesn't work like that. And to tie that into our reimbursement just simply doesn't make sense. So we sought to poke holes in that. So the first thing we looked at is age. So if you look across the board at our forearm fistulas, mid-upper arm fistulas, radiocephalic and brachiocephalic fistulas, and we looked at patients over the age of 72, it was a data break. I'm really sorry if I offended anybody in our elderly patient population. First, there was no statistically significant difference when it came to our functional primary and our functional secondary patency. And the reason why I emphasize functional primary and functional secondary patency is that these are the fistulas that worked. These are the fistulas that required maintenance, required interventions. And so we can look at the access that was successful and even show how in the most successful fistula, the ones that Fistula First holds up or CMS holds up as their ideals, there was still breakdown in terms of their expectation and from reality. So our outcomes were essentially the same in terms of our patency rates, but what changes is what's required to maintain that patency. So if you look, if someone is over the age of 72, their central venous catheter days are dramatically more if they have a radiocephalic fistula. So if you have a radiocephalic fistula and you're an elderly individual, your likelihood of maturing in a shorter window for that access is less. And unfortunately, and I apologize for the flip in the titles, this is significant because you're looking at a high rate of infection and bacteremia from your catheter, as well as putting that catheter in place and removing it is an expenditure for the system. And so then you go to your secondary interventions, and this is again the data that's lost to USRDS and to Medicare as a primary payer. If you look at what's happening in your interventions, radiocephalic fistulas require more work from both the physician and from the patient. They require a greater number of interventions to maintain their patency, and as we know, interventions equate to dollars and cents. And they also require a greater number of hospitalizations. Again, a marker of dollars and cents. So we can say, okay, you want a fistula for everybody? You can get a fistula in somebody over the age of 72. It's just going to cost you more money. So the assertion that it's the best access and the most cost-effective access isn't necessarily the case. We now need to say maybe brachiocephalic fistulas for patients over the age of 72 are the preferable access. And radiocephalic fistulas have a higher cost to the system and may not be the preferable access option because they are associated with a greater number of procedures. You can do that with gender as well. So we looked at gender, radiocephalic, brachiocephalic, and brachiobacillic fistulas. Again, no statistically significant differences when you looked at brachiobacillic fistulas. But when you focus on radiocephalic and brachiobacillic fistulas, you start to see differences in patency, in both primary and secondary patency. And again, more importantly, this is associated with an increased number of catheter days in women who are undergoing forearm fistula creation, an increased number of interventions in our patients who are undergoing forearm catheter fistula creation. And then you can say, in terms of our data analysis, that it's possible to achieve a fistula in a woman. We're not saying that you can't, and it won't be successful, and it won't mature. But what we're indicating is that radiocephalic fistulas and brachiocephalic fistulas have statistically significant differences in terms of what's required to keep them patent and open over the course of that time period. And achieving that patency has a cost to the system. So if we're going to advocate, again, fistulas first for everybody, we now need to be asking which fistula first for everybody, and in what patients. So we'll keep going. Just a few more data slides, and I promise we'll go on to something else. If we look at the history data then too, a lot of times our literature says, okay, we'll try a fistula first in the forearm, because maybe, just maybe if you put it in as a radiocephalic fistula, that's the most distal fistula first, it'll plump up the veins that are more proximal, and you're more likely to have a successful fistula in the upper arm too. So still go with your fistula first. But we looked at that as well. And if you looked at the Mount Sinai data, unfortunately, it doesn't work out that well. And if you look at your one-year thrombosis rates and your primary failure rates of doing a fistula in a non-virgin arm, they are worse than if you do them in a virgin arm. So this is comparing our brachiobacillic fistulas, the fistulas that are above the elbow, after people have had an intervention below the elbow or in a virgin extremity, and you see that there's a significant difference in the number of interventions required to keep that fistula patent. So why is that important? Again, it focuses us in on the question of which fistula first for which patients. And you cannot come up with a blanket recommendation for all of our patients, because Fistula First Breakthrough Initiative, it does just that. And then we go to the meat of the issue, the meat and the potatoes, which has to do with cost. And so this is where we can take our data with regards to the number of interventions, the number of procedures required in order to maintain functional patency, and actually link this into a dollars and cents analysis. So what we were able to do is a cost analysis at Mount Sinai. We took all of our patients who had had functional access for 2 years, and we did a chart review, we spoke to the patients, we looked at all of the interventions, all of the ultrasounds, procedures, CT scans, MRs, anything required to diagnose and keep that patient's fistula access open. And then we assigned it relative value units from 2013, and we didn't use any modifiers or adjustments. We tried to keep this as pure as possible. This is an example of what would be billed for creating access open if you're doing, let's say, a transluminal balloon angioplasty of the central venous system and a thrombectomy for included access. And you can do data analysis in terms of cost and cents. So again, no difference in our cohorts. What we start to see is now there are cost differences. And as I said before, we've linked cost with number of interventions, number of catheters, number of things required to keep this access open. So we haven't done anything to alter the purity of our clinical data or change our clinical recommendations. We've just taken our data and put it in a way that someone who's making policy would have to respond to, or someone who's, let's say, an MBA guiding hospital administration would have to recognize. So you see that if you're putting a radiocephalic fistula in a patient, and they happen to be a woman, it's going to cost more within the first year. It's going to cost more in the second year, and all these differences are statistically significant. It's going to cost more in the brachiocephalic fistula region. It's going to cost more in the second year as well if you do a brachiocephalic fistula. If you break it down by age, there are statistically significant differences in terms of what it costs to maintain functional patency based on your age as well. So if you look at women who are over the age of 70, it is cheaper to have a brachiobacillic fistula in terms of the system costs in the first year than it is to have any other access. And the same is true and holds out to the second year as well. And if you just look specifically based on age, you then see that there are statistically significant differences based on gender, age alone. And additionally, then you can come back and say, look, if you're designing policy based on fistulas, and we're looking at this as the cost to the patient and the cost of the system, now you can't say that access alone, fistulas are cheaper than grafts. So you have to go back and now prove that with grafts, and that's exactly what we did. We look at all the grafts that were placed at Mount Sinai that had 2 years adequate follow-up from the years of 2004 to 2011. We created these cohorts. We were able to analyze them based on which graft material was used, which DRG codes were billed for, and then we were able to look at the location, whether they were in the forearm, the upper arm. The most important thing first is to say, our results are standardizable. So what does that mean? It means if you look at our patency rates for arteriovenous grafts over the course of their life, we hold up or exceed national averages. So our data should be representative of what the rest of the country is seeing. And so our cost data should be accurate as well. And so if you look, you start to see that the assertion that fistulas are cheaper than grafts actually breaks down when you look at the Mount Sinai experience. And so policy that's based solely on cost containment measures and encouraging arteriovenous fistula creation over graft doesn't necessarily work out for every single patient or across the board. And if you look at how this cost distributes, the question is, well, what about your outliers? Are you doing an outlier analysis? Now, if you look at the dollars and cents, I'd say you're absolutely right, that's a great criticism. But what I would also point out is it depends upon what you're billing for. And this is an appropriate thing to talk about when we're talking about policy. So sure, if we look at all of our patients that were included in this study, and this is representative of their individual costs, the majority of the patients are, essentially cost contained. They don't require any interventions in their first year. They were relatively stable. And there are a few patients which you can say, these are your outliers. These are the ones that cost the most. Well, we actually did Grubbs analysis. We went back and we looked for outliers in terms of the number of procedures, what those procedures were, and how often they were occurring. And there was no statistical outlier in terms of our data analysis. This is important because the procedures and what they're being billed at and what's done in the operating room is surgeon dependent. And it's sort of that clinical decision making you make in delivering medical care. And what we're showing is there's variability in that and what's billed for. But if there's no variability in what's occurring to these patients, and there's no outliers in what's occurring to these patients, you have to account for the variability in billing in terms of doing cost analysis. To say it another way, if everybody's having the same procedures done, there are no outliers in terms of what procedures are done to maintain their access. The outliers are in terms of billing, and it goes back to that gray area. There's no right, there's no wrong, and physicians are left to determine what the best procedure is for that patient at that time. And the same thing holds true in our second year. Again, what you would call a few outliers, I would actually call a few of our gray area billers, and the rest of the patients tend to be cost contained. So what does this mean? Well, the cost of graft access in terms of what it actually costs the system isn't captured by USRDS. And the cost of creating that access is not captured by USRDS. And the Fistula First Breakthrough Initiative is inappropriate in saying that fistulas are across the board cheaper than placing grafts. So we have to do more analysis, and we have to study these things in order to come up with good policy. And this is also true then in talking about system costs, and this is part of the most important thing that we're going to talk about today. As we move towards the Affordable Care Act's emphasis on accountable care organizations, one of the big things that's going to happen is you're going to get a lump sum for a patient, and you need to deliver care within the bounds of that lump sum. So it's in your best interest to control the outcomes for these patients. Right now, there's a lot of data in the hemodialysis access literature that says an interdisciplinary approach is the best thing for these patients. And that's absolutely right. But what happens when you have an interdisciplinary approach? Patients can still go wherever they want to go. Well, you can do a medical record review, do the same sort of analysis that we did at Mount Sinai, and we were inspired by this patient who's over here on the right, and the patient had a beautiful forearm fistula, but then they came back to us with this wonderful stent which precluded them from any future upper arm access options. So by simply placing stents over the confluence of the basilic and the cephalic veins, the subclavian vein, essentially now American Access, whichever outside facility put this stent in place, precluded them from having the next step surgical option. So when you go back to that individual care team or that medical care plan that was put in place by you as the surgeon or you as the provider in conjunction with your PA, physician extender, the nephrologist, whatever that was usurped by somebody else on the outside with a financial incentive to do so. So we did that. We found out how much money does Mount Sinai lose per hemodialysis access patient on a yearly basis because we have attrition. We can't keep our patients cost contained. And in actuality, it's a lot of money. So when you look at this as an example of a billing protocol that we used for billing, and what we did is we maximized the billing for every procedure. So if a patient went and had a balloon angioplasty, a balloon venoplasty at an outside institution, we said, you know what, if we don't see a stent on a chest x-ray, fine, it was just a venoplasty. That's the maximum they would have billed for. But if we see that stent, we're going to assume that they put the stent, they did the venoplasty, they did their thrombectomy, they would have maximized their billing opportunity because why wouldn't they have? They're a freestanding dialysis access facility. And you go back and we looked at our fistulas, somewhat similar demographic data from earlier, and we found that the number of procedures performed outside of our institution was almost 1/3. So in terms of capturing our maintenance procedures for a hemodialysis access patient population, we lost 1/3 of our subsequent work and patient follow-up. And I say it's work and I say it's follow-up because it's dollars and cents for physicians and providers in the hospital, but it's also adherence to a care plan that could have kept our patients' fistula open longer. And again, the patients who went to an outside facility had a greater number of procedures performed. There is a global period, so if you go to American Access, they'll send a shuttle to your house on day 91, pick you up, bring you back there for your diagnostic fistulogram. No data to support it, no data against it currently, and the recommendations and billing allow for it. So people are incentivized to continue providing that care. And we go back to Nancy Curie's research at the Brigham. And she's saying that, until you come up with strict guidelines to limit these behaviors, people are going to do what they see as being pro-quality, but also pro-earning potential. And that's exactly what happens in dialysis patients. So going back to this incredibly complicated table full of dollars and cents, I just want to call your attention to a few things. Again, this takes all the data we did from our fistula analysis earlier on, puts it in one place, and shows you that hospitals stand to make a lot of money in terms of procedures and pro fees and physicians as well from providing dialysis maintenance. Now, if you break that down to 300 patients, you simply take 300 patients at Mount Sinai who are having hemodialysis access, maintenance, and creation services provided here. If you assume that 1/3 of all their procedures go somewhere else, in the first year of creating maintenance alone, for every 300 patients, Mount Sinai loses almost $2 million. And then by the second year, that number increases to another $2 million. And so the total amount spent outside of our institution is essentially 1/3 or 36% over the 2 years of creating and maintaining functional arteriovenous access. So this is an incredible amount of money, or more importantly, we can talk about money when it comes to policy, but I view this as a departure from the care plan. This means somebody went somewhere else and their care plan was interrupted. And so maybe somebody put a stent or a balloon angioplasty which prevented me from doing my next step, or me providing my next guided care option for this patient. So if you look at this, you can say, great, so radiocephalic fistulas and brachiocephalic fistulas have higher 1-year and 2-year functional patency costs. And they're costlier in patients over the age of 70. And they're costlier in patients over the age of 70 if they also have a brachiobacillic fistula. But the more important thing is, not only if you want to influence policy, do you have to say that these have cost associated with them, but that these procedures have a cost to the patient as well. And those are more procedures and more interventions. So one last thing to talk about is how we also guarantee quality in a different way. When it comes to vascular access, there are vascular access complications. And to me, this is somewhat preposterous. Hemodialysis patients go to hemodialysis 3 times a week. They see a nurse, they see a nephrologist, they see a healthcare provider at least 3 times a week. Yet they present to the emergency room with things like this. And this is one of my favorite videos from intern year. And essentially, this thing is ripe for rupture. You can see it glistening as it expands slightly underneath the skin, and it is essentially about to kill this patient. And I literally mean it's about to kill this patient, because 1 person every day on average in New York City, based on aggregate data, dies of fatal access hemorrhage. And the people who are essentially detrimentally impacted by this are the patients, because they aren't captured and there are no penalties. But if we're being proactive and thinking about policy changes, in the future, you as the access provider will be penalized if your access fails. So unless we want to be dinged for the fact that these patients have ulcerated, infected accesses that are seen multiple times a week, even though we only see them once every few months, we need to be proactive in providing data that says we should not be the ones held responsible. That's exactly what we did at Mount Sinai. So we looked at the Center for Medicare and Medicaid Services data on fatal venous access hemorrhage, and they said 1,654 people died of this rupture. And this is another photo from the Mount Sinai emergency room. When these things are ripe for rupture, they're ripe for rupture, and I do not believe this happened overnight. And I didn't notice this yesterday. It's just preposterous. So nationwide, again, many confirmed cases. If you look at a retrospective review of the coroner's reports from Maryland and DC and Virginia, 88 confirmed cases over 5 years. These patients actually are investigated because they look like murder scenes. When they rupture at home, this patient actually went to a homicide detective because someone thought he was stabbed. In actuality, it was just an access rupture. He tried to put a tourniquet on his arm to make it to the emergency room in time, but he died. And so if you look at our Sinai experience, if you looked at all the access that we created between 2012 and 2014, 231 access creation events, 138 of them were fistulas, 93 were grafts, and then we did 111 revisions. So about a third of our cases were maintenance procedures. Of those revisions, 38 were emergent. So we had those patients present to our emergency room with a rupture or a near rupture with a sentinel bleed, and that's about one patient every other week. And so if we look at our data, we can be proactive about it. We can say dialysis access facilities should be penalized if a ulcerated or a near rupture event occurs, because that means that they were not adequately surveilling the graft or the fistula. And furthermore, we can even be proactive in suggesting policy for grading our aneurysmal degeneration of fistulas. And that's something that Dr. Shanzer and Dr. Hedorescu have worked extensively on with the Bragg criteria, creating a grading scale, grade 1, grade 2, grade 3, grade 4, to help encourage hemodialysis access facilities to have the appropriate tools at their disposal for grading these access-related complications. And it also gives you guidelines: observe, surgically evaluate, urgent repair or emergent surgical repair. And thus we see the genesis of policy or evidence-based guidelines that can be linked to payment methodologies in terms of who should be penalized and why we shouldn't be penalized for these complications. And that's the most important thing when we come back to our iron triangle. How can we look at cost, how can we look at quality, and how can we look at access and find a way to intervene as policy is ongoing? So in conclusion, as I talked about hemodialysis access a lot, and a lot of the work that we've done, one of the things I want to emphasize is that everybody should be doing this. And if you look at this sort of wheel of how policy is created from the CDC, there's this assessment, there's this policy development, and then there's this assurance phase. And one of the things I want to encourage people to not do is be responsive to policy. I think that as physicians, we are the most capable in terms of anticipating the needs of our patients and understanding what they're going to require in the near and short term, as well as the long term as well. And if we can focus our clinical research and focus our understanding of outcomes and what they necessitate in terms of the system, then we can really be instrumental in securing good policy for them in the future. And that just means linking our clinical research with cost-benefit analysis and really encouraging that dialogue between the policy wonks and people who are making healthcare policy and people who are delivering healthcare. Thanks.